We can move on to the next session, that is cellulitis. So here actually cellulitis is the bacterial infection of the skin, and rarely it may occurs with Haemophilus influenza, but category is bacterial infection of the skin. Okay, rarely comes with the viral problems. We can see detail of the cellulitis. Definition: it's an acute spreading bacterial infection below the surface of the skin characterized by redness, erythema, warmth, swelling and pain. So here the cellulitis means it's a infection that spread below the surface of the skin. Below the surface of the skin means there will be epidermis first layer, then dermal layer will be affected, then subcutaneous layer will be affected. Okay, so all three layers usually affected by the cellulitis. Then what will be the characteristics? There will be redness. When we are touching the area, there will be warmth. Then when we are observing, we can see the swelling. Then when we ask to the patient if it is painful, the patient will say yes. Okay. So that is the definition of cellulitis. It's a acute spreading of bacterial infection, especially below the surface of the skin, characterized by redness, warmth, swelling and pain. Cellulitis occurs when an entry point through normal skin barriers allows bacteria to enter and release the toxins in the subcutaneous tissue. So when a disease is occur, definitely there will be a reason, there will be a root. Okay, so when there is an injury to the skin, the bacteria will be enter into the skin and they may release their toxins. Okay. Usually the causes of cellulitis include Staphylococcus, Streptococcus, group A and B, then Haemophilus influenza, that is especially in periorbital cellulitis. Periorbital cellulitis means the cellulitis that occurs especially the below the eye or the around the eye. Okay. Then there may be chance for the facial cellulitis. Okay. This picture explains you which all are the areas cellulitis is affected. So you can see the epidermal layer is affected, dermal layer is affected and subcutaneous tissue also be affected. Okay. And in the more serious condition only deep subcutaneous tissue will be involved. Now we can see which all are the risk factors for the cellulitis. We have seen the causative agent for cellulitis, that is the Staphylococcus and Streptococcus, etc. Right? So in the risk factor or the etiological factors, the first one is crowding. Okay, crowding means overcrowding. Okay, in case of overcrowding, there is a high risk of infections because there may be chance for the infected people. So the overcrowding that may leads to the spread of infection. Then contact. Okay, contact with the infected person. Then compromised. That means there will be cut in the skin. Okay, so there may be easy chance. And if the patient is immunocompromised, okay, if the patient is diabetes, the patient will be immunocompromised. And if there is a small cut in the skin, the bacteria will easily enter into the skin. Okay, and the preventive ability that will be less for this diabetes patient. So the compromised skin, that means there will be open cut. So easy entry of bacteria or the immunocompromised. That means the patient has no immunity level. Then contaminated surfaces. Okay, when you are touching the contaminated items or contaminated surface, there may be chance for the infection. Then lack of cleanliness in the home or in the area you are working. Okay, or if the patient have no personal hygiene. Okay, everything may cause the cellulitis. So when you are thinking about risk factors of cellulitis, you should remember these 5 C's: crowding, contact, compromised, contaminated, and cleanliness. That is lack of cleanliness or lack of personal hygiene. Okay. Now we can move on to the symptoms. Now we can move on to the symptoms of cellulitis. So here the person will have the redness, red streaking in the skin. Okay, there will be a red stroke in the area which is affected. Okay, then swelling. Okay, while observing we can see the edematous skin. Then when we are touching the patient or localize the area is affected, when we are touching that we can feel the warmth. Okay. Then pain or tenderness. Okay, the patient will have the feeling of pain, and when we are touching there will be tenderness. And sometimes there may be chance for the leaking of yellow clear fluid or pus. Okay, due to the usually there may be purulent exudate, or sometimes there may be non-purulent cellulitis. Okay, so that is based on the bacteria is affected. So usually there may be leaking of fluid through the skin. Okay, edematous skin is more chance to damage. In this picture you can see one leg is unaffected and another leg is affected with cellulitis. You can see the redness and you can see the edema, right? And there will be a marking, okay, how much it is affected. That's why the doctor put a mark here. Okay, and when it is reduced, it can be easily identified while we are marking the skin. We actually regarding the pathophysiology, we don't have exact pathophysiology, but when there is a cut in the wound or in the skin or due to fissure or any laceration or due to insect bite, anyway the bacteria will enter into our skin and it will reach into the subcutaneous tissue, and from there they will start release of enzymes or exotoxins, and that leads to deep inflammation. Okay, and that leads to the cellulitis and the clinical features. Regarding the diagnosis, as usual we can assess the history of the patient. During that we can assess is there any cut injury, or if the patient is diabetes, patient come from overcrowded area, or personal hygiene can be assessed. Okay, contact infection is present. Okay, regarding the etiological and risk factors, you can assess the history. Next, physical examination. So in the physical examination you have to check the redness, warmth, tenderness, pain, edema, etc. Then complete blood count that leads to when we are assessing the complete blood count, there may be increase leukocyte count, that is WBC count will be increased. We will say leukocytosis. Then ESR level will be increased. Okay. So it is better to do CBC. Then culture and sensitivity usually we are doing in order to identify the bacteria. So that is regarding the diagnosis. We can move on to the management of cellulitis. In mild cases, it can be treated in outpatient service and oral antibiotic will be helpful to the patient. Usually we are giving dicloxacillin, amoxicillin or cephalexin group of drugs. Then amoxicillin, all these drugs are penicillin. Okay. Cephalexin is cephalosporin. Then if the cellulitis is severe, the patient needs to be hospitalized and we have to give intravenous antibiotic at least 7 to 14 days. Then the general measure, we have to immobilize the area, then elevate the extremities in order to relieve the edema, then provide moist heat that promotes wound healing and improves the circulation. Moist heat that will improve the circulation, so the wound healing process will be easy. This is the drug that can be given for the cellulitis patient. The first drug of choice is penicillin group of drugs. Especially we have seen dicloxacillin, amoxicillin, etc. Then cephalosporin, that is cephalexin, cefazolin, etc. Okay, all these drugs you will study in pharmacology, don't worry about it. Then macrolides. So in that erythromycin and azithromycin can be given. Then clindamycin can be given. Then vancomycin. Then linezolid. That is intravenous or peroral route can be given. You just list down the names of the drug. Okay. So these all are regarding the cellulitis. Now we can see a small condition, again a bacterial infection of the skin, that is erysipelas. Here it is a rare infection and we can't say it is easily available in our or easily seen in our hospital. Anyway, erysipelas is a diffuse spreading skin infection without underlying suppurative foci. Here there will be red tender lesions raised above level of surrounding skin and clear line of demarcation of involved tissue. So erysipelas means it is the diffuse spreading infection. Okay, there will be spreading, underlying spread of the infection, and usually there will not be suppurative foci, but the most of the common features or common causative agent for this erysipelas is the beta hemolytic streptococci or group A streptococci. Okay, so here when we are observing erysipelas, we can easily identify because there will be red tender lesions and it will be raised above the level of the surrounding skin. So when we are observing the patient, we can easily see these red elevated lesions. Okay, usually involves lower extremities. So we can correctly mark the area of the patient where it is affected. So that is the main peculiar feature of a erysipelas. Okay. Then cavernous sinus thrombosis is an important complication on face involvement. In this picture, you can see erysipelas of the legs. So here The lower leg is red, hot, tender, and edematous. Erythematous plaque is well defined. The infection is recurrent with the interdigital tinea pedis as the portal of entry. So when the patient have tinea pedis infections, okay, that time our skin will be injured. Through this skin, the streptococcus or staphylococcus organisms will be enter into the body and leads to the erysipelas. Okay. Now we can see the treatment modality. Usually the penicillin and erythromycin is the drug of choice. Okay, usually need treatment and it can be resolved by the penicillin and erythromycin. So that's about the erysipelas. It is very small condition. Okay, now we are completing with the bacterial infection of the skin. We have seen impetigo, folliculitis, pharyngeal, carbuncle, cellulitis, and erysipelas. Other infections are there, but it's not necessary for our second year. Okay, so we just completing the bacterial infection of the skin.